this is a brief background. Now, when we started researching this healthcare policy framework, our idea was to give this review starting from 1983 onwards, because that was the first time when National Health Policy 1983 was announced. But then when we went back, we realized there were much more literature even before 1983. And then we came across one very well-researched, in-depth report by which was called Bohr Committee report. It was, the chairman of that committee was Sir Joseph William Bohr. He was an Indian civil servant, and he was Diwan of the Cochin state. So he prepared a 3-volume, very nice report, and it has some 26 experts, including some experts from outside. So when we started researching, we found that was very, very useful report. So, and in fact, I may say that was one of the finest reports I've ever come across on any subject. So 3 things I will talk about. If you review the history of healthcare framework, 2 things come repeatedly, recurring theme occurring in every policy, whatever we have adopted from time to time. One is about the universal health coverage. Though the term was not used, the term came into usage only in about early 2000. But in some form or the other, every committee, every report which went into this healthcare policy framework, they recommended some form of universal healthcare. And number 2, every policy talked about developing primary healthcare infrastructure. Virtually every policy, and there was a lot of emphasis on primary healthcare infrastructure even in the Board Committee report. So what I will do, I will show you 1 or 2 quotes from that committee, which basically explain the thought process of that committee. Please go through it. It basically talks about the universal health coverage, though the term was not used as I mentioned, but it's all about universal health coverage. I don't want to repeat it. You can all read it. But what it basically, it set the tone, and it keeping in mind this, it made wide-ranging recommendations. And now, can we go through the other? This was 1946, before the independence. And one important thing which when we were reading the report, we came across was this observation. We talked about health from the economic development point of view now, but this committee talked about the positive impact of health, not only for the individual well-being but also for the economic development of the country way back in 1946. And if you see that Human Development Index, which was first computed by the UNDP in early 90, they mentioned both health and education. So that was the thought process of the committee. It was, I would say, that committee was well ahead of its time. So when we reviewed the healthcare policy framework, let me go through 3 major policies which were announced. One was in 1983, second came in 2002, and third came in 2017. In between, a flagship program called National Health Mission. First, it was National Rural Health Mission, then it was subsumed into National Health Mission in 2015. So they are the 4 major healthcare policy frameworks. So in 1983, the policy recommended health for all, but unfortunately, the committee wanted to reduce a government expenditure on health. It wanted to leave it open to the private sector. It was a bit intriguing that they wanted health for all, but without government spending. 2002 policy, there was some confusion as to what should be the role. It talked about the role of the center vis-a-vis states. States health is a state subject. So there was some confusion. I would say if you go through the report of that National Health Policy in 2002, it was with the view that most of the resources for health should come from the states, because health is a state subject. But the state center should play only supplementary role in that. But then it also felt that the states were not doing enough. If you see the data which we'll show you later, you will find that insofar as states are concerned, their share in total health spending of the as percent of GDP was 0.7% in 1991, which got reduced to something like 0.57% of GDP in 2020, 2001 or 2, when this policy was being framed. So it realized states were not doing enough. Then it mentioned in the report that center should play greater role in healthcare. That's how it was. Then came 2000, and it also set the target actually of 2% of GDP, that health spending by the state and the center should be 2% of GDP. But not much had happened. Then came 2017 policy. 2017 policy was very categorical that health spending needs to improve. And unless you improve health spending, out-of-pocket expenditure, which is basically inversely related, if the central government and if the public spending on health is more, then out-of-pocket expenditure should be less. So it was very categorical that no, we need to reduce out-of-pocket expenditure and the health spending needs to go. It made two things. One, it set the target of public spending on health to 2.5% of GDP by 2025, because we were only close to 1% of GDP then. And then second, it also exhorted states to spend something like 8% of its total expenditure on health. So these were the targets which were fixed by 2017 policy. And in between, of course, NHRM had come, which had talked about that health spending target of 3% GDP, but that was not much talked about later. So first, so I'm saying the three repeated themes which we find, of course, first two were universal health coverage and primary health care. And starting from 2002 onwards, another theme was added, which was increasing public health spending on health. So we don't want to get into the features of each scheme, what each scheme said, suggested. What we'll go through, Aashi will present to you some major slides which talk about the outcomes of these, the assertions which these various committees made from time to time. I hand it over to you, Aashi. Yeah.
Okay, so I would first like to go over the mindset towards health that was prevalent before independence. When the then Viceroy, when asked about setting up a national health system, he said that productive items such as electrification, industrial development, irrigation projects, and agricultural improvement should come before unproductive items, I'm quoting, unproductive items such as health and education. Yes. Yes. So, the Boer Committee report was the first report to actually emphasize the positive impact of good health on economic growth. They also underlined that there should be proper integration of curative and preventive healthcare. Because while curative healthcare treats the disease after it occurs, preventive healthcare reduces the risk of it occurring at all in the first place. So it leads to a lot of cost savings also, because curative healthcare is much more expensive than preventive healthcare. So, so Boer Committee also made some wide-ranging recommendations regarding setting up of a national health system, setting up primary and secondary healthcare infrastructure, and related to health education and medical research. However, in the first 5-year plan, we realized that we do not have enough resources to follow the recommendations made by the Boer Committee. And also, in the early years of independence, there were widespread communicable diseases in our country. And the priority was controlling or eradicating them. So as we see, malaria cases, about 21.8% of the population in 1947 had malaria. So that stood high, very high in the priority of the government when it came to health. By 1980s, we see a sharp decline in the communicable diseases, although they were still not fully under control. But this afforded an opportunity for the government to now focus on developing a proper healthcare system. So it was only in 1983 that the government framed the first national health policy to improve the healthcare services in the country. The NHP 1983 was replaced by NHP 2002 and later NHP 2017. And there were various other schemes and missions also along the way, like the National Health Mission, the Pradhan Mantri Jan Arogya Yojana, the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, etc. So all of them were based on the theme of Alma Ata Declaration of Health for All by 2000, which was later popularized as universal health coverage. So the common thread prevalent across these policies was one, increase the public health spending, reducing the out-of-pocket health expenditure of people, developing primary healthcare system, addressing the rural-urban inequalities in healthcare, and achieving the ultimate goal of universal health coverage. So coming to the evolution of the health spending, which is the major prevalent theme in all these policies, we see that despite all the efforts and emphasis on improving public health spending in almost every policy, overall health spending remained largely low at 1% of GDP. In 23-24, it stands at 1.4% of GDP, which is way short of the target set by NHP 17 of 2.5% of GDP by 2025. And we see no efforts being done towards that because even now, the center's share stands at 0.3% in the present union budget. This pales in comparison to countries like Cuba, Colombia, Costa Rica, and even our neighbors like Sri Lanka and Nepal, which are spending way more, who are spending way more than us on health. This is also seen at subnational level. When we see poorer states like Meghalaya, Tripura, are spending way more on health than Karnataka, Haryana, Gujarat,
Maharashtra, Punjab.
And Maharashtra as well, and Punjab as well. So NHP 17 had set a target for states as well to spend 8% of their total health expenditure on health. And we see on average, it still stands at 6.2%. And most of the states are spending way less than 8%, even the richer states. Only Delhi, Pondicherry, Goa, and I think Meghalaya are spending more than 8%. So 4 out of 29 is not a good number.
So this is not just on primary or
No, this is
secondary.
total expenditure.
This is total
on health.
expenditure. Yes.
In that way, better because they have less.
Yes,
Yeah,
that is.
Yeah, absolutely.
Yes, that is true. That is true. Delhi and Pondicherry may be doing better because they do not have to spend on other. Center takes care of some of their allocations like police administration and all. But even then we see states like Meghalaya and Goa. If they can do it, then why not the other ones, right? So when we come to the indicators of health, the major ones being life expectancy, maternal mortality rate, and infant mortality rate, we see compared to 1991, we are doing much better now. But despite this progress, India continues to lag far behind its peers in some of the crucial health indicators. So suppose in life expectancy, we are doing better than only South Africa. In maternal mortality rate, we are doing worse than Philippines, South Africa, Brazil, China, and Sri Lanka. In infant mortality rate, we are doing better than only South Africa again. And this has led to, so we have one of the highest out-of-pocket expenditures in the world, standing at 50% of the total health expenditure. So So despite a lot of progress seen, we are lagging way behind our peer economies. So we talked about two common threads that were there in the policies. That was the improvement of health spending, the reduction of out-of-pocket expenditure. The third one was the development of primary healthcare system. And there are huge disappointments here as well, because there are huge deficiencies in terms of infrastructure and also the human resources in the health sector. So if we see here in the rural and tribal areas, we have not met the national norm that has been set by us only in 2011. So to give an idea, so the norm was that there should be one sub center in a rural area for 5,000 people. But even in 2021, we have a sub-center for 5,734. So we are nowhere close to the target. And the same for primary healthcare centers and community healthcare centers. If we talk about the human resources in rural areas, we see huge shortages in the sub-centers and in the doctors and the specialists in rural areas. As high as 80%, 87%. So this presents a really poor image of the current health system in our country. Urban areas are also performing very badly here. However, the situation is a bit better than rural areas. But again, this is not a good news. Moving forward, the ultimate goal of universal health coverage remains elusive because, as we see, we are more than 11 years behind China. So what China was in 2010, we are not that even in 2021. And compared to countries like Malaysia, Mexico, Brazil, they are all doing better than us to achieve the universal health coverage. Yes, sorry. Yes.
I'm just wondering
So how do you, in this case, define UHC, and is it comparable between the different countries in terms of amount of payment out of pocket?
So UHC is basically is how are you able to afford the healthcare services without facing any financial hardships? So every country has.
No, but this is basically by international organization which comes out with index. So it's apple to apple. So.
Okay.
So the key takeaways from the paper are that health has always been a low priority for the government. Despite policy after policy articulation of increasing the health spending, it has remained largely unchanged at 1 to 1.4% of GDP. It is disappointing that even after the harrowing memories of COVID-19 that starkly exposed the inefficiencies of our healthcare system, we have forgotten health, and we are not paying adequate attention to it. The out-of-pocket expenditure in India is one of the highest in the world at 50% of the total health expenditure. The primary healthcare is not receiving adequate attention, as we saw has been largely evident in the deficiencies in the entire system. There's inadequate health infrastructure and massive shortage of human resources. And even now, we see significant rural-urban disparities. And as we saw, the UHC goal remains elusive. So I would like to end it with saying that the government needs to come up with a strategical plan to improve the healthcare system, and which should firstly start by improving the healthcare expenditure. Thank you.
Thank you, Aashi, and thank you, Dr. Janak. And just to, add something on what we mean by universal healthcare, it's really looked at along 3 parameters. What health services are to be provided. To whom? That is the population. And ideally, we want to have for everybody, right? And third is at what cost? So of course, we want it to be as affordable as possible. And together they make up what we call the UHC cube. And there are indicators along each of these parameters. And as Dr. Janak said, they are measured across the countries in a standardized format. And that's how, we're able to compare. And of course, that's the, the primary goal. But I do want to start with the top line of what Aashi just presented about this low prioritization, and maybe ask, you to reflect first about, why you think, based on all of these schemes and this historical trajectory that you've looked at, why there is such a low spending, do you think?
So I would like to start by saying that I showed a quote by the Viceroy, the then Viceroy, that health, he considers that as a low priority when compared to other things like agriculture, defense. So even though he put it out, I feel that that mindset is ingrained in all of us, because COVID-19, I remember, it was, it was, all of us know someone who was affected by it, who had to go through a really hard time during that time. Yet, we have forgotten about all of that, and we are not talking about it. We are not asking the government, we are not holding it accountable that why are you not spending more on health? So that mindset, due to first reason is that mindset, that historical underinvestment in health, it is continuing because of that. Second, the prioritization of other sectors. So some sectors like education, agriculture, these have shown to be these have shown to be very fruitful when it comes to economic growth. What people don't realize is that health is as important. It is only because they are not able to see it, they are not able to identify that this is also one major area that needs adequate attention. Yes, so yeah.
No, let me supplement what Aashi has said. I think it's also a question of responsibility and the resources. Health is a state subject. And no, actually 1983 policy which I referred reflects that confusion. Central government feels it's a state subject and the state should spend more. And states have no resources. So central government has resources, but it's not able to spend. Actually, the 1983 policy confusion continued for quite some time unless 2002 policy came. And then there was realization that we should do something. As she showed the graph, public health spending by the state governments had been coming down instead of rising as percentage of GDP. It was in fact coming down. And it was only after the NHRM first followed by NHRM in 2050 that it started improving again. But we have not made much progress. Like it was 1% of GDP in 1991 and now 1.4%. Now, after how many years? After almost 35 years, yeah.
I was going to come to you with exactly this, sort of dichotomy, this, the federal structure of our country and why, and the way the Constitution assigns health as a state subject, and how has that issue been resolved, do you think, over time? As you mentioned, the NHM or the NRHM did come, and it did lead to an increase in spending, actually, at both levels. And now, what do you see the trends, moving towards as we prioritize UHC today?
Yeah, no, NRHM, or I will call NHM, did reverse the trend. But after initial years, after I think initial 5 years or so, it has again plateaued almost. In very recently, 2 years or so, there is some improvement in health spending by the state government. But there's no change. Like in 2024-5 budget, which the finance minister just presented, central government health spending is 0.27% of GDP as compared to 0.26% of GDP last year. So we don't find really much change. And we are far behind the target of 2.5%, which was set for 2025, which we are going to enter next year. So I'm not too sure how are we going to achieve that. It's impossible. It looks to me, yeah.
And actually, Aashi, since you've looked at the individual schemes, and maybe you've also looked at some of the levels of implementation of some of these schemes, I was wondering if there's also a split in the prioritization. I mean, is part of the reason why, as Dr. Janak is saying, there is this, poor prioritization and confusion, really, who is supposed to do the bulk of the spending? Is it partly because, the priorities of the central government in health, in the health sector, and the prioritization of health issues by different states is actually diverging? Would that be?
I think a lot of it has to come from the fact that there is no proper federal structure that defines, even in policies, in most of the policies, there's no proper funding pattern that is laid out. Like some policies do have a funding pattern being laid out, like 60% the states would do, 40% center would do, but most of the policies, they lack that. So, there's a lot of confusion there and a lot of, so when we have already India has a lot of committed expenditure, both the center and the state governments. So with that, the pressures of those, everybody, neglects health. They leave it to the other. States think the center should do it, center thinks the state should do it, it's a state subject. So, that confusion, that proper roadmap is lacking, strategy is lacking there. Because of that, I think there's so much
Just to say,
inefficiency.
play a bit of a devil's advocate, the government would say at the national level that it has introduced, for example, the world's largest health insurance scheme under the PMJY. It's a flagship scheme, and there's quite a degree of attention. It's also named after our PM, like many of our schemes are. So one can say that it's maybe the reason the allocations are low is because the states are not able to absorb, and this is a common refrain that we hear. And I wondered what you thought about it, just from both of you actually.
Yeah, let me come to you. Have raised very important question. If you see the data for health allocation, so of the total Ministry of Health and Family Welfare, the total budget, about 57% of that was going towards NHM. So once NHM and BEAM came, so that total share has remained unchanged, 57%, but a part of it has gone towards PMJ and a part of it has gone to BEAM. So that shows the commitment, like you have launched a scheme, but you have diverted resources from some other scheme. So that means now NHM will get less money. Let me also point out, 15th Finance Commission had gone into this issue. It made a special grant of rupees 1 lakh crore for states to spend on health. And then I think PMJ was getting launched, and it made some assessment as to what should be the expenditure if they have to cover people under PMJ effectively. The estimate which it made was in 2024, it should be like 1,66,000 crore. And what is that? What was the allocation in 2024? 6,000 crore. So 1,66,000 crore was the estimates. And another point about PMJ is about that things which is getting covered. So it covers only secondary and tertiary healthcare services. It doesn't cover primary. And the expenditure on primary care is something like 50%. That means half of the expenditure you are not covering as part of PMJ. And therefore, there are many other issues with the PMJ. Yeah.
Right. Actually, one related question with this low degree of investment, there's also a great deal of privatization in health, as you pointed out, but maybe it's also a common knowledge. All of us, when we have something, the first point of contact for us is typically a private doctor, a private clinic. And I was wondering, again, based on this historical trend, if you thought that privatization was a consequence of the low prioritization. So the government is not investing enough, and therefore the private sector has room to expand. Or is it the opposite, that because there is such a dominant private sector, maybe the government doesn't need to do as much, doesn't need to invest because there's already, and you pointed out, for example, the urban infrastructure, a lot of it is actually in the private sector. And therefore, maybe it's okay that the government isn't investing as much money. I don't know what each of you thought about it.
Yeah, you see that the government, I think since the government is not spending enough on, and that's how this private sector has come in. And this was reflected in 1983 policy. I will have to see actually how this private sector mushroomed after 83, because this was laid down in a policy that the government should not spending much on health. You leave it to the private sector. So this was a clear message that the government doesn't want to do much. So I would say that because the government is not doing enough, the private sector has come. Now it has become, big corporates have come in the area of health, like Max Healthcare, Apollo Hospital, and Escorts. So this has become, and in urban areas, of course, are well covered. But it's only rural areas where the people are poor, people lack understanding of, they are not very much health conscious. And, where some estimates were made that since the government is not spending enough, some 55 million people every year are pushed below poverty line because of the catastrophic health expenditure, which is a huge problem.
To add to this, I would say that right now it has become more like a chicken and egg problem. What is causing, what is the cause and what is the effect? It's unclear because historically the government was not spending much on health, so the private sector came in. Now, since the private sector is there, the government has maybe neglected the focusing on health. So
Let me also add one thing. We had done another study, which was released about 1.5 months back. So it basically about how the union government finances the healthcare in states. So what we found that most of the states, particularly economically weaker states, they depend more on general transfers from the central government for spending on health. So there are two kinds of transfers which are made by three kinds of transfers which are made by the central government to the states. One is under Article 270, which is basically, since the states have more responsibilities and less revenue, so that a finance commission decides every 5 years, like what should be the share which the state should get from the divisible pool of taxes. So those recommendations are made under Article 270. Then there is another Article 272 where finance commission makes some grants. But whereas under transfers under Section 270, they are completely untied because states have right and they have complete freedom to spend those resources wherever they want. But in case of transfers under Section Article 272, they could be tied or they could be free. That finance commission makes the recommendation. And then there is another article, Article 282, if I remember correctly, under which the central government, makes transfers to states, which under centrally sponsored schemes. So there are three kinds of transfers. So what we find that in the case of NHM, when the central government makes transfers to state governments, so economically weaker states, they depend more on general purpose transfer than the type transfer. These are type transfers in the sense the government will make transfers to states and they can spend only on health. They can't spend on other purposes. And there is matching contribution, like I think 60% central government makes and 40% state governments make. So what we found in that study is that economically weaker states not only depend on general purpose transfers, but they are also, since they have to make the matching contribution and the budgets are limited, so they are not able to, in order to make the matching contribution, they cut other health expenditure. So they basically substitute other health expenditure in order to meet the, NHM, targets. So the point is that since they have limited resources, so they are not in a position to spend. Of course, we do find some states spend much more than what capacity they have, like states like Karnataka, Maharashtra, Punjab. In the case of Punjab, we found another thing. Though its per capita income is where it has a huge budget and it has resources, but it has also a lot of debt. But if you adjust that their financial capacity for the debt it has and the interest payment which it has, like what we call in the study discretionary capacity, then it's very much less. But then as percentage of that discretionary capacity, it spends much more than that. So there are so many constraints which come on state.
Yeah, I think actually this is a very important point about even the funding through these big flagship schemes.
Yeah.
You mentioned, of course, the details with the NHM, but similarly also true for PMJ. A lot of the funding for, the prioritization of what this money has to be spent on, as well as how it needs to be spent on, is actually determined at the Government of India level, by the central government. And that definitely constrains the states in terms of what they are able to do, and some degree of localization, which was the original intent of the constitution in making health, a state subject, determining where the needs are. And of course, in order to, meet some of the other needs, which are also important and critical and cannot be taken over, states will often substitute these funds. And that's something that's not taken into consideration as much in this whole narrative of health as a state subject.
Yeah,
I
so
think that's
no,
a very
so let
important-
me point out another study which was done 2 months before the last study which I referred. So that study pointed out, so that study is basically based on discussion on, it's focused on NHM, and we had the discussion, I don't know whether Prajakta and Sandhya are here. So we had met the state government officials in 5 states. We had selected those states very carefully that they represent the, almost different political parties and different regions. So most of the states pointed out that they are mere implementing agencies. They have absolutely no say when this NHM is formulated, and they basically they don't own those schemes. So, but at the same time, fact remains that there's no state which has said they don't want to implement NHM because they need resources. Yeah.
And also on the point about, the privatization, you mentioned 83, and just an interesting, and fact is that the first Apollo of the country was actually came about during Rajiv Gandhi's prime ministership. So just putting that out there. In terms
Yeah,
of
so let me now, I recollect, that was a period between, I think, 2019, 84, 99, and before that 1983 policy had come. So it basically connects, like 1983 policy had said the central government should not be spending, should leave open to the private sector. So no wonder that Apollo Hospital came during that time. Yeah. 1983 National Health Policy. No, I'm saying 1983 was I think Indira Gandhi was the prime
he
minister,
was the prime.
and 84 she was assassinated, and then after that Rajiv Gandhi formed the government. Yeah.
So along this, along the same lines, actually, I was wondering about, you mentioned that there is urban health infrastructure is actually much better than the rural health infrastructure that's there, despite, for example, the original National Health Mission was actually a rural health mission, and it was considered to be fairly successful. And there was a lot of the resources, as Dr. Janak just mentioned, went there, not necessarily to the urban sector. So I was wondering, would you say that enough has been done in the urban health area in terms of just the policies and the policy attention that's been given, as well as the resources that have been come up? And here I want to just add one additional perhaps complication is, of course, we've been talking about this fiscal federalism with respect to the resources between the central government and the state government. What about resources, for example, at municipal bodies? And some of our municipal bodies, like Mumbai, for example, are quite rich.
Absolutely.
And I wondered if that complicated some of the investment that's gone towards urban health, and what your findings on that were.
So definitely, as you pointed out, that a lot of our policy focus has been on rural healthcare, but there is no major improvement even in the urban healthcare. Our urban healthcare system, although it is doing that better than rural healthcare system, but it is not really at a very good position. As we saw, there are large deficiencies in infrastructure and human resources, even in the urban areas. So urban healthcare falling out of the policy radar is a concern, and it should be talked about. And especially this becomes glaring because there has been large neglect of the urban poor that live in very unsanitary conditions and who are not even able to afford healthcare. So it is a very big issue, in fact, and should be talked about.
Yeah, no, Niti, let me supplement what she said. Of course, even in urban area, you will find some pockets, where you have everybody. Many people, even in urban areas, live in slums. Take, for example, Dharavi in Mumbai. Yeah. And there are many other places. I don't know other metropolitan, but I'm sure even there will be slums. So if you don't have good public health infrastructure, then how do they manage? But let me just come to this point again that I think this is one area which we need to study more. We have only talked about central and state relations in healthcare. But I think we've actually wanted to do, but not a part of this study, but otherwise, like what are the state and local level relationship in so far as health is concerned. I think that could be another interesting area to work on. Yeah.
And I think in general, even this research on understanding how the urban health issues are potentially different from rural health issues,
Absolutely.
there hasn't been enough attention. And what the policies should look like. I mean, should there be policies that are, more oriented towards rural and urban and so on, and different issues, and maybe further down to different states and geographies of the country. So I want to maybe end our discussion before we open it up to the rest of the room with just this last thing about, this overarching goal of universal healthcare. And maybe quickly from each of you, if you tell me what you think, where we stand in terms of, how we are doing on meeting this UHC goal and whether we'll make it by 2030, which is...
Yeah, she already presented a chart. We are lagging behind our other peers. But if we want to improve really universal health coverage, then it's very important that we increase public health spending. And there have been international studies in the international context. I have not come across any study in the Indian context, but there have been some studies in the international context. And WTO also has recommended that you need to raise a public health spending to at least 5% of GDP. So we are only 1.4% GDP now. That means we have a long, long way to go. So for this purpose, what we have recommended in our study, which we released yesterday, that in the next 8 years, both the central and state governments should raise public health spending by 0.2% of GDP every year. So then next 8 years, we'll reach the target of 3% of, we are 1.4% of GDP, we'll reach the target of 3% of GDP, and which is the basically average public health spending by the low and middle income countries. So we are far behind even that level. And then once we reach that level, I think then we should then set our sight on achieving the target of 5% GDP in the next few years. It's a Herculean task, if you ask me. It's not going to be easy, given the track record of last 30-35 years. But I think we need to make efforts in that direction. Unless we make those efforts, I think then we'll maybe talking the same thing 20-30 years from now.
And you have some thoughts about where that money will come from? I mean...
Yeah, see, if you see this, our chart which we showed, if you have, I think it's more a question of an intent than money. If you can find resources for other things, I'm sure you can. By the way, we are doing much better on education than in the case of health. Public spending on education is something like 4.5% GDP, which is again lower than what our peers have, but much better than what we have on health. I think you can find resources if you really want to do that. And of course, as the economy expands, you will have more sources. We know that. But if you talk about as percent of GDP, I'm not able to really visualize like what it could evolve like in coming years.
Yeah, I was just, as somebody who's been working in health, we've been trying to make this case to the finance ministry for a while. So I was hoping you'd have some additional, tactics to make that happen.
Right.
Did you have something to add, Aashi? Last thoughts?
No. I would only say that universal health coverage, that goal will remain elusive till we start paying attention, till the government starts paying attention to health. We see countries like Mexico, Malaysia, all of them are standing way better than us when it comes to universal health coverage. And I don't know if you paid attention to that slide, but in the last 30 years, Nepal has done so well in improving their health indicators, life expectancy, maternal mortality ratio, infant mortality ratio, even the out-of-pocket expenditure. So Nepal has done, it has shown huge progress. So if Nepal can do it, then India with better economic growth, it can do it. So again, I would like to reiterate Sir's point. It is a matter of intent and not resources. So
thank you for that.
My question was related to the last 2 points that both Dr. Janak and Aashi made, which is, see, the most of the conversation until now was about the funds, how much, what percentage and so on. And actually the driver is really the intent of the government. And that's related to, political pressure. Why isn't there? So I think it's an area of investing. I think that's where our focus should be in the research. Why is it that governments don't have that intent? And interestingly, if you look at Delhi, it's with this mohalla clinics, it'd be interesting to see what. Yeah, so it's actually the intent that came first, that we need to put up these clinics, and then they found the money and the funding, as you said, it goes up to 14%.
Yeah.
So I think the focus of the research should be on why isn't that happening? The funds will follow. I think rather than starting with funds, why don't we increase spending? Maybe better to try and understand why is it that the government or various governments don't, make this a priority.
No, absolutely. I agree with you, and you have rightly put it. I think it has not become a political issue. So long as it doesn't become a political issue, political leaders don't pay much attention. And that's the crux of the matter. In Delhi government, as some other governments have done, like Rajasthan government also has done better, I believe, than others, and even Tamil Nadu for that matter.
What's been what has been the improvements? What has been the result of the Delhi mohalla?
That part
has
we
been-
have not.
That deserves
Is it too
separate-
early?
That-
Is
that's
it
study
too,
of
that
its
too
own,
early
That we have
to?
not covered in our studies. So
No, I understand, but
Yeah.
I was just saying if you had some
I will not be able to.
the hunch or
Maybe let's
I
take
think-
these three questions and in the end reflect on some of these
No,
more.
but definitely I would say that, we should also talk about the quality of this expenditure and how it is being, so along with spending on health, there should be a proper strategy on the implementation of these policies. Definitely. Thank you.
So while it is true that India is underinvested in the healthcare, it's also true that just by increasing the overall expenditure on healthcare does not necessarily result in great outcomes. And the biggest example for that is the US. There the health expenditure is in the range of 16 to 18%, but the health outcomes are relatively very, very poor compared to many of the European countries. Second thing is, I think one interesting part of this whole focus on primary healthcare can be deduced on something which is more granular, which might try to see the impact of what is the investment of, let's say, per rupee in primary healthcare vis-a-vis tertiary healthcare. Because as you also mentioned, prevention is better than cure. So if you can do something at an early stage compared to a later stage, although the expenditure, overall expenditure basket would be still same, but still the impact could be very, very different. And the best example for that could be from immunization perspective. So it was exactly 50 years now since we had the smallpox epidemic in the country in 1974, which of course India sort of eradicated in 1979. We got free of smallpox. But starting from that perspective, and then of course polio and this whole thing around Indradhanush especially, and their impact in terms of the lot of communicable diseases, especially, I think that's important to look at. Of course, as far as the urban and rural is concerned, yes, obviously in urban areas, I would say lifestyle diseases, non-communicable diseases, the burden of disease is much higher of that type. But that's also increasingly being seen even in rural areas. Thank you.
No, I agree with
So
you.
actually, some of these studies on cost effectiveness has been done, but maybe let's take three questions and then.
She has just 4 questions, maybe we forget those. Let me just quickly.
Sure.
See, coming to your first question, absolutely, when we say that you increase spending, health spending, we also presume that you will spend it efficiently. And actually, by the way, next study which you're going to do is efficiency of health spending in India. We have already done it actually. So, but it's getting finalized. So it's absolutely, we need to spend efficiently. There's no doubt about it. Otherwise, you will not achieve the desired outcome. And coming to that, resources devoted for primary and secondary healthcare. So some years back, I think almost 20 years back, the target was fixed that 2/3 of resources should go to primary healthcare, and the remaining 1/3 should go to secondary and tertiary. But even after several years have passed, last data which we saw, only 55% of the total resources were being spent on primary healthcare. So we are not spending even after several years about 2/3 of resources on primary healthcare. And of course, we had major problem of this communicable diseases when we got independence. Actually, for 30 years we didn't mention. First 30 years we were struggling to bring communicable disease under control. We brought them under control by early 90s. And of course, now, as you rightly point out, there is a huge issue of non-communicable diseases now. So we need to pay much attention. But again, the question comes, how do you do that unless you raise the public health spending? Yeah. Well, otherwise, people will pay. See, health is such a thing, people borrow and then they will pay. But is it a good thing for society as a whole? That's the thing which we need to ponder over. Yeah.
A wonderful presentation, Aashi. So I had just two questions. You have in one of your slide, you have also mentioned that the number of doctors and healthcare professionals across rural and urban areas. So I wondered, just have you also looked into the doctor-patient ratio, and like not only doctor, like maybe healthcare professional and patient ratio across the rural and urban areas? Because in rural areas sometimes it's very dismal. There's an acute gap. And also my second question is about the access to the entire healthcare infrastructures, maybe it's primary healthcare centers, like whatever. So, and over the years, since we are discussing about healthcare spending over from the budget and all. So over the years, like, did it change? Because in urban areas, what happened is like we are talking about like urban poor slums and all. So there's also a hindrance is also access to that maybe it's private or government medical care facilities. So, and like what is the role of the like ULBs, like urban local bodies to manage that? So it's just a clarificatory question. Thank you.
Can we take that? And then there is one online, and then maybe we can answer that.
Sure.
Yeah. So thanks for the presentation and discussion. So just two questions. One is the fact that the state health is a state subject shouldn't really be a hindrance for center to invest, because you see that clearly in electricity sector where electricity distribution is a state subject. But the biggest scheme where the center gave grants through electrification, RGGVY, and that was continued, that really made rural electrification possible. And 90% was grant and just 10% was state contribution. So one can, think, why is that not done in health? So clearly going back to the question of intent and the political will for it. The second related point to that is one sees a lot of government interest in infrastructure spending. So whatever little spending that is happening in health, is it also towards building buildings and hospitals and more beds, or is there also qualitative investment in the sector? Those were the two.
You can want to take first question, come to her question. Yeah.
Yeah.
So,
Yeah, go ahead.
So Tanima, you talked about the doctor-patient ratio. So when we showed the shortfall of doctors, so that is determined by a norm that takes into account the population in that area. So, so there's a doctor for certain population, and based on that, we have calculated the shortfall in the system. So it essentially takes care of the doctor-patient ratio and all of those as well. I forgot your second question, but your third question. The access to healthcare for the urban poor, the role of urban local bodies, right? So again, I think Delhi is setting up mohalla clinics and all these things. But again, like Sir also mentioned, that the states, and they do not have the autonomy to spend as they want to, as they would like to. Center controls a lot of it. So I think there is some friction there that needs to be taken care of.
Yeah, no, let me come to you. You raised a very interesting question. See, there has been a lot of debate. Actually, this matter went to the Supreme Court also, because central government also spends a lot of money through centrally sponsored schemes. Whereas Finance Commission, 15th Finance Commission, if I remember, Dr. Reddy was the chairman of the 15th Finance Commission. They wanted that the 14th Finance, so 14th Finance Commission had recommended that more and more resources to the state should go from, by way of general purpose transfer, which the state should be able to spend. If much before that, in some context case, a matter had gone to the Supreme Court and it was challenged the central government should not be, sponsoring any centrally sponsored schemes. So, but then Supreme Court set aside that thing and said no, central government has the right to do that. So, but despite that, this controversy continued because the central government was spending a lot of money through centrally sponsored schemes. And 15th Finance Commission as well as 16th Finance Commission, they also made recommendation that the central government should spend, not much through centrally sponsored scheme. They should transfer those resources to states and leave it to them wherever they want to spend. But if you see now, particularly after I think 16, 17 onwards, there has been a sharp increase in resources which are getting transferred to states through centrally sponsored schemes where states have absolutely no control. And most of the centrally sponsored schemes are on state subjects, which are under the domain of states. So as we found in the case of other study, that you depend more on general purpose transfer for spending on health. So if the state government, if the central government is not giving them money through centrally sponsored scheme, but giving them through general purpose transfers, I'm sure the outcome would be better. But the fact of the matter is that there has been proliferation of number of schemes have come down, but the amount, because some of the schemes after the recommendation of 15th Finance Commission, they were transferred to states. But the amount which is getting transferred to state through centrally sponsored scheme, that has increased sharply. If you compare them, their own revenue, states also have their own sources of revenue. If you compare the two, I would the data which we collected, there's no much gap now. That means the states are depending as much on centrally sponsored scheme as on their own resources for spending.
Yeah. Let's take the online question from Sharad. He's pointing out, you have pointed out 4 states that spend greater than 8% of the total state expenditure or budget.
I'm not able to recall which was the
Which is the largest
in terms of area. And
how has that state basically how
Which was the largest in terms of area of population that has the highest share, meaning of poor and developed. How has
So we
that state
can-
managed to increase a higher share of expenditure?
also what is the typical share of curative versus preventive care within the total expense? So the 2 things he's asking, how has this one state managed to spend so much more than the average? And second, what is the share between curative and preventive?
Yeah, so I think this is again question of if you some union territory, Delhi is not a full-fledged state, but still they don't have responsibility for police administration. So they have more resources to spend. Maybe this is one of the reasons. But we have also seen some of the rich states like Karnataka, then even Tamil Nadu for that matter, Punjab,
Gujarat as well.
Gujarat, Maharashtra, Karnataka, Maharashtra, they are not spending much. So if they have resources, they are not spending much on health. I don't know really. Again, it boils down to whether you have intent to spend or not. That's it. I didn't get what was it? You want to attend the second
Preventive
part?
versus curative.
So the preventive versus curative. So the recommendation was we should spend 55% on primary healthcare, which basically translates to preventive care, or I am not sure about the typical share that we are doing right now. But yes, I can set that.
Yeah, but
Yeah.
bulk of it is going again for curative, not for, if you spend more on, preventive, you will have less need for spending resources on curative healthcare. So we will do, I don't have the readily available number with me, but I'm sure that bulk of it is again being spent on,
So we'll quickly
curative
take
healthcare,
the
yeah.
last question from Alok and Karthik. First to Alok.
Thank you for the presentation.
Yeah.
I think the entire debate was reduced to health financing. So let me just ask, go back to the question what Neeti had asked Aashi, that why do you think that health was not a priority even before the first health policy came in 1983, the background of it basically. And if you could briefly touch upon, so if I can clearly recall the various committees that were formed before 1983, they actually pointed towards the systemic level factors that were actually creating issues in terms of accessing the health system. And so why do you think that, up till, 2005 when NRHM came, before that, the focus on systemic level factors, so in terms of infrastructure, HR, that was actually somewhere, not focused or left behind. And so apart from funding, of course, public financing was one key area, but other than that, the systemic level factors, despite being repeated recommendations, why it was not being implemented over the years.
Yeah.
So let me
Okay.
just, let's take card just because we've run out of time. And then I'll give Dr. Mohan one
Sure.
last question and then we'll end there.
So I had one question and one clarification from one of the slides. Firstly, on health becoming a vote bank issue, and does the panel's experience say that health has never been a vote bank issue at all, or it has been a vote bank issue but has been addressed differently? Like they've not increased expenditure, but they have found other ways of answering that as a vote bank issue. So I'm wondering if health has just never been a vote bank issue at all in India. Secondly, in one of the slides, we see an index on universal health coverage. And Ganesh and I both found it a bit difficult to probably understand how the index is working, because does higher score on the index mean you have been
You
able to
achieve
do
better, yeah.
you have been able to cover more population under the universal health coverage, or you've been able to create more factors? Like, how do you break down that index in itself? Because it says that 68 was India's mark, and I'm not really sure what it means when you say 68 on 100 is where India is on universal health coverage. It just sounds astounding. Do we think India is 68% covering the population, or factors? It has met certain parameters at a 68% mark. So just wanted to understand more of the index here.
Thank you. So I have sort of questions, stroke comments, and maybe Niti will be able to answer some of them, given a long time work on health policy. One key question, actually, last two questions, beginning of what you said, that why has it not been a priority? We can't say government priority. Why is it not, and the question you asked, that has been a vote bank? Why has it not been a priority from the people's side, right? And one index, I suggest, Niti, you could do a survey in CSEP. Among all of us in CSEP, how many of us provide for health insurance for our helpers at home? I'll give an index of whether we care about healthcare. And it's a very difficult issue because it is a very relevant point what you have said, that usually government reflects what kind of pressures people they get on different issues. And somehow, is it because we are much more we are much more class conscious, or that the elite is much more separated, so they couldn't care less? So that's a very, I don't expect an answer from you on this issue, but I think that's something to really think about. One other sort of comment, sort of question on the issue of state subject, that a lot of the criticism that many of us make is that we are too centralized, and that many things like education and health, we had a long discussion on education yesterday with Amarjit Sinha and other education specialists. And there's a lot of opinion which says that health and education should be much more decentralized, because you have to be nearer the people in these sectors. So I think that's to sort of say, why is it that the problem is because it's state subject? Then it's sort of implying that the government entity that is nearer the people cares less about health. And again, the same question arises, why is that the case? One question on all the shortages, Neeti, this for you, since I missed your presentation, unfortunately, on the shortages in the medical education system. Given the huge employment problem in the country, it's very difficult to understand the shortages. Doctors will understand because IMA has been a problem, etc., but to some extent has been solved. But all the other health workers, why is there a shortage? Given the huge employment problems, and that now we have 10 million graduates a year coming out, BAs, that is, a year. And I mean, the gross enrollment ratio in higher education has gone up from 8% in 2000 to around 30% now. So there's huge increase of people with some level of education. It may be useless, but the point is they can at least read and write. So they can be all kinds of health workers that are needed. On one issue on specialist rural areas, again, the question is that since we now, how many districts? 800 or so? About 700. So the point is that specialists require enough patients. So you can't have a specialist in a rural clinic. There's no way. But because we have so many districts, there has to be, in some sense, the issue then is of access, not putting the specialists in the rural area. I've said this in many of our papers, actually, this rural problem, but it doesn't make any sense to me that specialists have to be in an urban area, right? But of course, you need to provide access to transportation, referrals, and so on. In just one specific question, are the urban local body expenditures included in your government expenditures? No. So that is something that I don't know if any data are available.
That's a separate study which we contemplated once, but we'll have to see. Yeah.
Okay, so that's basically the other thing, just on the CSS, semi-sponsored schemes. We had this discussion on education yesterday, and one of the things that was said was that when you increase central expenditure through centrally sponsored schemes, basically states basically substitute.
Yeah, absolutely.
So you don't have.
That's what we found. That's what we found. Yeah. Overall expenditures. Yeah.
Many other things that I just thought I'd do.
Yeah. Yeah, no, coming to your first question, of course, which is Avicii, also the vote bank, it's very difficult to say. I think it has not been, vote bank issue so far. Maybe in Delhi it has been, but I don't know about other places. Maybe Rajasthan is another state where it was some issue, and I think that government did well. So public also has to demand. I think public have just accepted. Yeah, public has to demand. Public has just accepted whatever, the treatment is being meted out to them. And then, of course, you said that the government, of course, it's also the responsibility of the government. When the government, yeah, but individuals also, absolutely, I think we don't care for, people who are poor and around us. This is something which everybody has to,
and this is when
Suppose it's usually illness across households, but rather than provision of insurance, a lot of the medical expenses are often picked up.
Yeah.
And because the insurance products are usually in such a way that the OPD is not covered. There's no OPD coverage. There is no reimbursement of diagnostic tests. And so it's not this, it's only hospitalization.
Yeah, no, that's only PMJ. Yeah, even otherwise also, even otherwise also, absolutely. Even otherwise, no, absolutely. Even otherwise also. Even otherwise also, yeah, it's only.
Where is the maximum amount of their expenditure is on OPD and advice for diagnostic tests. It's a huge cost. An ultrasound costs anything between 2,500 to 3,000 rupees today. And none of these private hospitals who are supposed to actually have an EWS quota or something, they're just not implementing it. In fact, Narayan Hospital, which is near my home, I inquired about that. And they said that, oh, we do it as part of our CSR or some such thing. They're all dodging it merrily.
Yeah, and because of many other things, but absolutely that insurance is not a solution
Yeah.
unless you get hospitalized.
Yeah.
Yeah, absolutely.
Thank you.
Yeah.
I think since we've run out of time and way past it, even though there are some questions, I think we'll have to take it up individually. Just a couple of things to say on all of the questions that have come up, I think, and feel free to add maybe. One is this notion of health as something that this distinction, and actually your work also showed this transition between health as care and services, right? Once you fall sick, then you need the doctors and the medicines and so on, versus the public health system. So the intent of the government should actually be that you should never have to go to a doctor in the first place, or as rarely as possible. And whether the system is investing in that. And I think that's the point about the preventive and actually health promotive. And that shift both in our thinking, and that goes back to the point about whether or not there is a vote bank and demand from people, is we only think of health when we actually get sick. Whereas we need to think of health as public health and much more than, doctors and hospitals and so on. And a related point also, this elite privilege of doctors and this extra power that we give to doctors within the system. And we as people, in the news media, for example, every time there's a health issue, there is a cardiologist from some big hospital on the panel. And similarly for the policymakers, and a lot of the policy advice have been taken also from tertiary care hospitals, and that points a little bit. In terms of whether there has been vote bank, actually, some of the schemes, the precursor to the PMJY was the RSBY, and before that, the original scheme was actually the Arogyashree scheme from the undivided Andhra, where just in a public meeting, people said, oh, I'm spending so much and I'm entering poverty because I can't afford to get my cardiac, heart surgery done. And Rajshekar Reddy said, oh, the government will pay for among the poor people. And that's how the Arogyashree scheme came about. And that was tertiary insurance, originally actually for heart surgery. And then that became eventually the RSBY, and it's many versions now. And that's also partly why the current PMJ actually only addresses hospitalization. And I think Alok's point is, of course, very well taken, that it's only about financing. And actually, there are a whole bunch of issues, interconnected issues that are taken up. And in terms of shortages on other cadres of health professionals, that's a very important point for two things. And it's related to what I was saying about this extra emphasis and sort of attention and power that we give to doctors within the system. Whereas actually, for a public health system, and what the government should be investing is on all of these non-doctor cadres. The most important person in a public health system is actually the community health worker, not the doctor. So whereas all of so how many GPs are even practicing? Again, that goes
in the public healthcare system.
Yeah. So there are a lot of
that is part of primary healthcare actually.
Yeah. So just to say why they aren't, currently the salaries are so low that they can make up those same amounts through just any menial labor. Even a doctor in a primary health care, the GP, the MBBS doctor, the primary health, the PHC officer, medical officer, is paid something like 30 to 50,000 a month. And he's only takes up that partly because they have to fulfill a rural bond, or sometimes because they're using that time to prepare for their PG study. And it's just an easy posting, nobody cares, or they can get away with not necessarily attending. So the amount of money, and that goes back to the point that the study is making about, how little money is going into health. Where should it be directed towards? Towards paying the salaries. For example, the community health workers are actually still volunteers technically. Yes. They're not official cadre. They don't get a salary. And they're all women, by the way. So on that note, I think we've well short past. Thank you for all your questions, and we should continue these discussions.
Thank you. Thank you.